Welcome to our webinar. My name is Dr. Gary, and I'm the Chief Medical Officer for Fertility Cloud. Along we have Amy Beckley, who is the CEO of MFB Fertility, and we're going to go ahead and get started without any further delay. So this is going to focus on your particular questions. We've tailored the presentation to answer the questions in order that you've asked them. But if you don't see your questions asked and answered during the slide deck, we'll answer them in the Q&A, so please be patient with us. I will allow Amy to introduce herself.
Yeah, thank you, Dr. Gary. It's amazing to be here. I thank you very much for allowing our community to have this hour with you to explain what Fertility Cloud is, how it might benefit for them, and to answer their specific questions. I'm the founder and the inventor of the Proov test, for anybody that doesn't know. I have a PhD in pharmacology. I've done hormone signaling. I was also infertile for 3 years, went through multiple rounds of IVF to find out that I didn't need IVF. I just needed more information about my body and my hormones, and I actually got pregnant naturally after I found that out. That led me to have the passion and desire to not only educate women, but empower them with better solutions so that they can reach their goals faster. So I'm excited to show you guys Fertility Cloud and kind of as a way to complete that treatment loop. Proov helps you understand your hormones. Now you have that information. How do you get access to a physician that can actually use that to treat you? So thank you for letting us in and giving us an hour of your time, Dr. Gary.
Oh, it is our absolute pleasure, as I think the integration of our two philosophies should definitely assist as many patients as possible in achieving their dream on their fertility journey. So my name is Dr. Gary. I am a board certified reproductive endocrinologist. That means I am residency and fellowship trained in obstetrics and gynecology, and also in reproductive endocrinology and infertility. And we started this clinic as a way to make fertility care accessible and affordable for everyone. So what is Fertility Cloud? Fertility Cloud is basically an online clinic that allows for online consultation, testing, and treatment to be done strictly through telemedicine. So that means you do not have to interrupt your life, you do not have to interrupt your schedule in order to seek care with a reproductive endocrinologist to receive treatment and testing for any fertility questions or concerns or pathology that you may or may not have. So we do request that you participate in our webinar today. I think that your active participation will allow you to get a lot more out of it. And so, like I said, we've built our slide deck in order for us to answer your questions. But if you don't see your question answered directly in the webinar, we'll answer it during the Q&A. And unfortunately, if we don't get to it during the Q&A, then we will go ahead and email you a response after this is over. So everyone that's participated, we want to extend our gratitude to you, and we want to ensure you that we're going to do our best to ensure that whatever question or concern you have, we'll answer it to the best of our ability. So what are we going to talk about today? Basically, we'll kind of do an overview of what infertility is, what normal fertility is, how you can optimize your fertility, what are some common causes that would prevent you from getting pregnant in a quick and reasonable manner. What are some treatment options? What is the efficacy or the effectiveness and the cost of some of those treatments? And then we'll go through lifestyle interventions, anything that's procedure-based, medical-based, and then we'll answer directly the questions that were submitted to us. So if you guys could answer your first question, and are you currently concerned about your reproductive status or reproductive potential? Let me minimize this so I can see. And then go ahead and answer the questions in the slide below, and then we'll have your results for you in 1 second. So the vast majority of the responders and the participants do have some concern. So what exactly is infertility, and then do you have a problem or not? So these are very dogmatic approaches to this. This is what the American College of OB/GYN and the American Society of Reproductive Medicine defines as infertility or subfertility. So women who are under the age of 35 typically are given 12 months to conceive. And women who are over the age of 35 are typically given about 6 months to conceive. And then the recommendation is that then you seek some sort of care. Now, it doesn't mean that if you can't be seen or evaluated before this time if you think you have a problem or if there's a natural problem. So I don't want you, or I don't want your physicians or people taking care of you to be very dogmatic about these numbers. And you should definitely advocate for yourself if you think there's an underlying issue that should prevent either yourself or the people taking care of you from making you wait this long. And so what are those issues that, in the opinion of established medical practice, should prevent you from waiting that long in order to seek an evaluation or care? And so for women, if you have irregular or absent menses, now typically that's defined as menses that are shorter than 21 days or longer than 45 days. If you have negative ovulation kits, if your timing or your basal body temperature isn't rising, any history of a pelvic infection, or a prior history of infertility, those are all reasons why you should not allow anyone to force you into those very rigid and dogmatic treatment algorithms. For men, if there's any medical problems associated with genitalia, for example, a prior mumps infection, any history of trauma, a varicocele, or if there's any abnormal sexual functioning, for example, difficulty obtaining an erection, difficulty with ejaculation, those are all potential signs of low testosterone that will potentially lead to sperm issues, which will delay your time to conception. Now, those times that we've previously discussed are all based on couples who don't have any issues getting pregnant. And so if there are underlying issues, there's absolutely no reason to wait that long, because the statistics are going to be much, much different. And so unfortunately, reproductive problems are increasing in the United States and all over the world. Part of that is people are delaying childbearing, and that causes more difficulty conceiving. Other problems people run into is that treatment is becoming very, very expensive. And there's a paucity of reproductive endocrinologists in the United States and worldwide. So those are all reasons why we've established Fertility Cloud to make reproductive care accessible and affordable for everyone. And so let's take a look at this slide. And so what this demonstrates is normal probability of conception per month in women and men who have no pathology. So at the prime of reproductive potential in the 20s and early 30s, even in the best case scenario, the probability of conception per month is somewhere between 20 and 25%, and it really never goes over 25%. So again, in the best cases, the probability of conception is only 1 in 4. And so sometimes it does take 4, 5, 6 months to conceive, but again, this is based on no pathology, and that probability does significantly decrease with the age of the female. And though this is not pathologic, this is physiologic. And so we have to be able to harness the physiology or circumnavigate the physiology to increase the pregnancy rates in women who do get older. So this is a reminder of how to answer questions and ask questions in our webinar. Again, all the questions are private and anonymous, and we'll be ensured to answer all of them to the best of our ability as we're going through this. And then our staff is going to help us with the ongoing Q&A as well. So the next question is, do you think lifestyle changes are effective in helping you conceive? So this is a common theme that we saw in the questions being asked, and also a lot of social media does revolve around menstrual cycle. When is the most optimal time to conceive? When should women and men have intercourse in order for to obtain that best probability of conception every month? So if you take a look at both of these graphs, basically this does, again, simplify things a little bit. But if we look at a standard or a median or a mean menstrual cycle, so no one's normal, no one's going to be exactly what we described in the medical literature. But if we take, 1,000 women and count their menstrual cycle, the most of them will fall into this 28-day or 30-day window where ovulation typically happens somewhere around day 12 to 14. And so the phase before ovulation is called the follicular phase, because the follicle or the cyst where the egg grows, it develops. And then the phase after ovulation is called the luteal phase, because the cyst where the egg grows and then leaves the ovary becomes what we call the corpus luteum. And basically it's Latin for this yellow material. And so the dominant hormone before is called estrogen, and the dominant hormone after is called progesterone. And the cells that secrete progesterone are basically the granulosa cells that become luteinized and form this yellow material in the cyst in the ovary. A lot of the questions revolve around cysts in the ovary. And so the vast majority of cysts that you see on a regular ultrasound, or a doctor says, oh, I saw a cyst when I did your scan, are actually physiologic, meaning that they're not pathologic, they're not abnormal. That's where the egg actually lives, and that's where the cyst has to form to feed the egg all of the nutrients and the metabolic materials in order for the egg to develop properly. Cysts only become problematic when they grow to be a certain size that can be symptomatic, or they're abnormal. So things like precancer or cancer or endometriomas, cysts that are abnormal are pathologic. But the vast majority of cysts that develop in the ovary are actually physiologic, or we expect them to be there. Now, the best time to have intercourse is what we call the fertile window, which is the 5 days before ovulation. And so for a median 28-day cycle, that's day 11, 12, 13, 14. And the highest probability of conception happens the day before ovulation. So this is what we call the implantation window. And so if people have intercourse after the implantation window, the ovulation, then the probability of conception is essentially 0. And the probability of conception in this phase is also very, very low. And so how many times should you have intercourse? Based on the latest data and the latest mathematical modeling, it appears that every day within the implantation window has a higher probability of conception versus 1 or 2 days or every other day. Again, that may not be feasible for everyone, and those are statistical and mathematical models. And the difference versus every day versus every other day is actually pretty small. But mathematically speaking, the highest probability of conception happens if every day of the fertile window intercourse occurs, and then the day that's the most likely to lead into a conception is the day before ovulation. Now remember, some women's menstrual cycles are 32-day long, some are 24 days long, so they're very, very different. So typically, the luteal phase, which is the phase after ovulation, is about 14 days. Now, 12 to 15 days is normal. If it becomes a little bit shorter, then we consider that luteal phase deficiency. And so if your periods are not the typical 28 days, then if you count 13 to 14 days pre-menstrual, that's when ovulation typically occurs. All right. So we did cover how often should I have intercourse. What sexual practices can improve the chances of conceiving. A lot of this has been studied, probably in the 60s, 70s, and early 80s. And typically there isn't anything specific. As long as there's one active intercourse in the fertile window with ejaculation in the vagina, that's all that's typically needed to achieve conception. there's a lot of things that I see on social media that people recommend, but going back to the medical literature, there isn't anything specific that we recommend except for an active intercourse without any lubricants that can potentially be toxic to the sperm. Now, let's talk about lubricants quickly. And there's a lot of controversy surrounding it. And most of that data is based on sperm studies in the lab. So basically they take sperm, they put it in the petri dish, they add lubricant to it, and they see what percentage of sperm stops moving in a certain way. And they say, oh, this lubricant is toxic to sperm. The environment inside the female is much different than an in vitro lab. And the sperm, we know, swims into the cervix and into the fallopian tube very, very quickly. So it's unlikely that in a natural environment, any specific lubricant will negatively impact the clinical pregnancy rate, even if it impacts sperm behavior in the laboratory. So my recommendation typically is whatever works for you as a couple in terms of a lubricant should be okay. Without saying that unless there's a sperm abnormality that can be impacted further by a specific lubricant. What about lifestyle? So what does lifestyle have impact on your fertility? So there's a bunch of things in lifestyle that we like to address at Fertility Cloud. Things that you can do to improve your chances of conceiving, and further, things that you can do to improve your chances of any kind of intervention. So for example, if you're doing IVF, or if you're taking Clomid, or if you're taking any other fertility medicines, or you're doing IUIs, what can you do at home to make those things more effective? And so there are things that we know is problematic, and then we speculate on things because the data is controversial. So the one thing that we know is problematic is smoking. And so even if you or your partner smokes, or if you're around an occupation where there's a lot of smoking, even if you're not smoking, inhaling that smoke, any metabolite of tobacco, we can actually identify in the fluid around the egg, and it causes problems. So within the ovary specifically. So if you can avoid smoking, avoid tobacco, avoid interacting with other people that smoke, that would certainly improve your chances. The issue that we find is that even if, let's say, your partner is a smoker, but they're smoking outside and they practice really good hygiene after they're done smoking, the majority of the smoke that's inhaled actually goes into the lungs. And after you interact, that smoke is still inhaled through that interaction. And then we can find that within the context of the ovary. Alcohol. The vast majority of time, if you're not using alcohol during your treatment cycle, for example, whether you're doing Clomid or IVF, it's really not an issue. But if you, for example, started your treatment, whether it's oral or injections or anything like that, we see that alcohol can have a negative effect. So abstaining from alcohol during treatment is what we strongly, strongly recommend. What about exercise? So exercise has multiple ways it impacts your success rates. We do know that women that have a moderate or recreational exercise program, so for example, they exercise 30 to 40 minutes a day, it doesn't really matter what they do. They can lift weights, they can run, they can swim, they can go to the gym. Those women have a higher probability of conception with treatment than women who are sedentary. Now, the women who exercise to exhaustion, 5 to 6 days a week, meaning that they're completely exhausted by the time they finish their workout, they actually do a little bit worse than women who exercise recreationally. So what we always recommend is a moderate exercise program of whatever type of exercise that individual prefers or is able to be consistent with. And that's much better than being sedentary, and that's also better than exercising to complete exhaustion. So what about caffeine use? We do know that consumption of about 300 to 400 milligrams of caffeine correlates with the increased probability of miscarriage. We don't understand the mechanism, but we recommend that women decrease their caffeine intake when they're trying to get pregnant. And the safe limit is probably about 2 to 3 cups. So more than that, or equivalent, more than that is probably problematic. Less than that, it would be fine. But there's absolutely no reason to completely eliminate caffeine intake if that's something that gives you pleasure or you enjoy. So what about diet? Diet's a big controversial topic as well, and we don't really know what the best diet is in order for you to conceive. The data that's out there, kind of looks like this. We've taken women who are doing IVF and we put them on different diets and we see who can do better. Now, as you can imagine, it's very difficult to enforce a particular diet in any study, but that's the best data that we have. And so compare it to everything, it looks like that the Mediterranean diet, so basically a diet that's very low in processed food, high in fruits and vegetables, high in fish, about twice a day, low in saturated fat, those women, when they underwent IVF, did better. Now, it's difficult to extrapolate that to women who are not doing IVF, but that's kind of the best data we have. So we do recommend for women who are trying to conceive to go on a Mediterranean type diet. So that kind of covers the lifestyle. And unfortunately, there's so much on the internet that may be controversial, or maybe different people have different opinions on it, that it's kind of tough to find what would be the optimal lifestyle intervention. But in terms of what we discussed, that's what we recommend as Fertility Cloud, and I hope that helps. So let's go to question number 3. Have you inquired about fertility treatment on the internet? And I think a lot of the people that I speak with, that's the #1 place they go, and unfortunately they end up being more confused than when they started. So about 70% of fertility patients, this was based on a study, believe that the information they receive is complete or biased, and that's 100% accurate. Unless you're going to go to a reputable website like the American Society of Reproductive Medicine, the European Society of Human Reproduction, the American College of OBGYN, a lot of that data, a lot of the other stuff that you see is, again, subjective. A lot of that is opinion, but you understand that all of the organizations as well, all of the opinions are being written by people interpreting the data. So most of the information does have some bias in it. And then how many of you guys have been diagnosed with infertility or subfertility by your reproductive health professional? So let's talk about when you actually see a doctor, what are some of the diagnoses that you can run into? And so we definitely break this up into men and women. And then for men, and this is actually the most common thing that we find, is if we're going to go looking for couples who are having difficulty conceiving, identifying a sperm problem is actually much more common than identifying a problem with the female. And then that accounts for about 1/3 to a little bit more than 1/3 of all issues that in couples who are trying to conceive. When we look only at women, there are essentially 4 things that we look at. The first thing is what we call ovarian reserve. And the ovarian reserve is this umbrella term for the quality and the quantity of eggs left in the ovary. And we can only compare that to women of the same age. So for example, a woman at 35 is going to have a different ovarian reserve than a woman at 25, then a different ovarian reserve than a woman at 45. And those women are going to have different probabilities of conception. So what that means is, what is the probability of conception for women who are the same age as you, based on the testing that we've obtained? And so that's age dependent. And for some women, a low ovarian reserve is, again, not pathologic, that's physiologic. because that's what we expect, and that's kind of the way our species at this point at least are. And so the second thing that we identify is issues with the fallopian tubes. Now there's multiple ways for us to look at fallopian tubes, but the fallopian tubes can either be open or closed, and we can test for that, but there's no way for us to test fallopian tube function. Now remember, the fallopian tube is kind of like your nose. It has these cells with hair in it that propel the egg and the sperm towards each other, because we have cells in our nose that with hair in it that prevent bacteria or viruses from getting into our lungs. They function similarly, but obviously the purpose is different. And so anything that can obstruct the fallopian tubes can actually cause damage to those cells that propel the egg and the sperm towards each other within the fallopian tube. And so sometimes, even when we can tell that the fallopian tubes are open, we have no way of testing fallopian tube function. And then we look at ovulation. So typically women that have regular cycles, because bleeding is a result of progesterone withdrawal, we can presume that ovulation is normal. Now there's other ways to document ovulation: progesterone levels through the blood, progesterone levels through the urine, LH testing, temperature charting, and obviously pregnancy. But if we're looking at strictly at females, ovulation issues are the more common problem that we identify. And then a lot of what we see is that women come to the doctor, they have their sperm checked, they have their AMH or their ovarian reserve checked, they have their fallopian tubes checked, they have your ovulation checked, and then everything looks okay. But unfortunately, based on age, they haven't gotten pregnant within that specific window that we previously discussed. And so they get the diagnosis of what a lot of people call unexplained infertility. So I think that's a bit of a misnomer, because for whatever reason, you haven't gotten pregnant within the statistical probability that we expect you to get pregnant in. And just because we don't have a diagnosis for you doesn't mean that it's unexplained. I like the term undiagnosed. So to me, that there probably is some sort of underlying issue, whether it's fallopian tube dysfunction, whether it's ovulatory dysfunction, whether it's an issue between the sperm and egg interaction, or an issue between the embryo and uterine interaction. We just don't have a test for it. So a lot of the treatment that we would recommend in the future is empiric, or we give you things to overcome that without clearly understanding what the diagnosis is. So let's look at ovulation. So as you can see, ovulation is a pretty complex concert of hormones and molecules and eggs and fallopian tubes and everything like that. So typically what happens in the hypothalamus, which is a region of your brain that sits right above the pituitary gland, it releases what we call gonadotropin releasing hormone. And that gonadotropin releasing hormone is released in a pulsatile fashion, meaning it goes like this in a cycle. That hormone acts on the pituitary gland, which releases LH and FSH hormones, again, in a pulsatile fashion. These hormones act on the ovary in the follicular phase to secrete estrogen. When estrogen gets to a certain phase, it triggers what we call the LH release, and that's what women typically measure in their ovulation kits. And once that LH gets over a certain threshold, that's what triggers egg release. Now, let's talk about the LH surge. The LH surge lasts anywhere from 24 to 48, and in some women 72 hours. And so typically ovulation occurs after the initiation of the LH surge, or you can time it from the peak. Now, some of the kits have darker lines, and some of the kits tell you peak, no peak, but typically it's very difficult to detect a peak, because remember, the LH goes up and then it comes down, and it depends on when you're going to test. So in my opinion, it's better to detect the start and to count from the start. So typically you're going to ovulate anywhere from 48 to 72 hours after the start. and about 24 to 48 hours after they peak. Now, again, everybody's very different. In some women, again, the LH surge only lasts 24 hours, so some women don't pick it up. Typically, it starts in the morning and ends in the morning. So my recommendation is you test in the early afternoon or evening, so you pick up that rise in the hormone if your peak or if your surge is only 24 hours. So as you can see, there's a lot of hormones that, again, have to act in concert for this to occur. So any deviation from what we typically expect can result in anovulation. The most common reason for any kind of problem with ovulation in women is called polycystic ovarian syndrome. And cysts in the ovary in that syndrome is a result, not a cause of this issue. So what's changed in the last 5 years is, in my opinion, that this has significantly revolutionized how we can test, detect, and evaluate ovulation and ovulation quality. Now, before you had to, for example, go to the doctor and get your progesterone level checked. And if it's over a certain threshold, people could have confirmed ovulation for you. The problem I have with that is that it's simply one piece of information in time. And again, remember when I talked to you guys that everything is secreted in a pulsatile fashion. And so progesterone is secreted from the ovary in response to LH, again, in a pulsatile fashion. So your progesterone can be 5 at time 0 and 25, 45 minutes later. So just measuring one progesterone level, to me, can only tell you one thing, whether or not you've ovulated. It doesn't necessarily tell you anything else in terms of the quality of your ovulation, the corpus luteum quality, and the luteal phase. And so what these new home tests have provided for us is the ability to determine essentially the quality of the luteal phase in addition to confirming your ovulation. And it also allows you to not have to leave your home to get the information you need, which in my opinion is very, very beneficial. So moving on to fallopian tubes, we briefly talked about this, but again, if your fallopian tubes are obstructed, then unfortunately the probability of pregnancy is very, very low. Now, some of the questions that we've had submitted to us was, what if only one fallopian tube is open? And so if only one fallopian tube is open, it should not impact your pregnancy rate. Excuse me, what it does is impact your time to pregnancy, meaning that women with one fallopian tube sometimes can take longer to get pregnant. So for example, sometimes women only have, they've had a tubal ligation and I do a tubal reversal surgery. And for technical reasons, we can only reattach one tube back together. And so the probability of pregnancy in those women is no different than the probability of pregnancy if we put both tubes back together. It just takes longer. And sometimes women are only born with one fallopian tube and they never know about it because they get pregnant and they don't have any problem. So having one fallopian tube blocked is not really an issue. The issue is fallopian tube function. Any process that causes a blockage of fallopian tube, typically on one side, can cause dysfunction of the tube. And even if the tube on the other side is not blocked, there may be some dysfunction. And so, like we talked about earlier, the most common reason why fallopian tubes are blocked or not functioning properly is a prior infection. Most commonly, it's called pelvic inflammatory disease or chlamydia. And so, if you've had any kind of prior infection, you should be screened or tested for fallopian tube obstruction, because that would be much more common in somebody who hasn't had that risk factor. The other common risk factor for fallopian tube blockage would be something called endometriosis. And typically women go through 5 or 6 doctors and years of going to medical professionals before they're diagnosed with endometriosis. Now, endometriosis typically presents with painful periods, or pain between periods, or painful intercourse. Now, if you're in a position where you dread your periods, they're incredibly painful, you have to take medicines that are more than over the counter during your menstrual cycle, very likely you have endometriosis, and you should ask your doctor about it. And just having endometriosis, even if it doesn't impact the fallopian tube, could put you at risk for infertility or subfertility, because everything about the disorder can impact the probability of conception. So let's talk about ovarian reserve again. We saw that graph of the probability of conception in the beginning of a webinar. And so why does that happen? Conception has to revolve around the quality and the quantity of the eggs in the ovary. And so the way humans are designed, every month there's a group of eggs that the hormones that we talked about before recruit. One of those eggs becomes the dominant egg, and that's the egg that's ovulated. But that group, whether it's 12 eggs or 30 eggs, that dominant egg comes from, undergoes a process called atresia. So those eggs don't ovulate. And so as that group becomes smaller and smaller and smaller, that process leads to a decrease in the eggs left in the ovary. Again, there's nothing wrong in women who have a decreased ovarian reserve. That's just kind of their physiology. The issue is this graph can be a little bit faster in some women and a little bit slower in other women. So everyone is, again, very, very different. And that discussion has to be done on an individual basis. So for example, in our practice, we don't have age limits. And even in the IVF practice that I have here where I am, we don't have age limits, again, because everyone's different and this curve is different for everyone. Typically, we test ovarian reserve with AMH, or anti-Mullerian hormone, and that correlates reasonably well with the probability of conception and the probability of response to ovarian medication that would lead to conception, whether it's IVF or whether it's oral medication. We start seeing subtle drops in pregnancy rates like we discussed before after the age of 37, whether it's natural or whether it's pregnancy that's assisted. And after a certain age, again, everybody's different. It depends on how this process is in your ovaries. But this sometimes can lead to irregular cycles, and then ultimately, when the number of eggs is exhausted, it leads to menopause. Again, so what has changed in the last 5 years? So all this testing can now, again, be done in the comforts of your home. So what we can do is we can send you your AMH test. There's no reason for you to go to the lab and have this painful blood draw. It's a simple finger stick, and then we can get your AMH levels to you within a week or so. Now, again, AMH levels correlate to your probability of conception, whether it's spontaneous or whether it's assisted. And once AMH goes under a certain level, specifically 1, in combination with your age, that may be an indication for you to be much more aggressive in terms of trying to get pregnant. So moving on to sperm, again, if we were to identify a problem, the most common problem we identify is a sperm issue. And so typically when we look at sperm, we look at the number of sperm in the ejaculate, the number of sperm moving forward, because sperm have to be able to swim through the cervix and the fallopian tube and fertilize the egg in the fallopian tube. And then we look at the number of normal appearing cells, because the vast majority of sperm, unfortunately, because there's billions and billions of them made, are actually not normal. And so the more abnormalities there are on the sperm analysis, the lower probability of conception for that male. Now remember that even if the sperm is abnormal, it doesn't mean that that particular individual is sterile. It means that the probability of conception is lowered for that individual, and you may need assistance conceiving. Now, whether it's that assistance is some sort of lifestyle modification or treatment for the men or treatment for you, that's a discussion depending on what the abnormality is that we find. Again, all of this testing can now be done at home. It's extremely accurate. It's much more convenient than going to a sperm bank and providing a sample in an uncomfortable testing room. Again, you do not have to interrupt your lifestyle or your schedule in order to have these tests done these days. All right, so next question is, have you received treatment for reproductive care from a healthcare professional? Because now we're gonna move into treatment, and so hopefully we can answer a lot more of your treatment questions in this aspect of the presentation. All right, so I am a reproductive endocrinologist. What does that mean? It means I trained, God, how long has it been now? About 12 years just to help couples conceive. And so reproductive endocrinologists, again, focus on both women and men. So I have male patients and I have female patients, and we treat them both. We have much more experience directly doing fertility. So we have access to latest data, latest literature, and we integrate that into our treatment plans. And that allows us to make the treatment much more individualized versus just giving a specific medication in a standard treatment algorithm that may or may not be successful. And then we specialize in couples and in women who are what we call maybe lower prognosis in order for them to be successful. All right, so have you been recommended IVF? And so we'll talk about IVF here as well. Problem is, a lot of the health plans in the United States do lack coverage. Some states are great, but most states unfortunately not. And the average successful IVF patient ends up spending a lot of money on assisted reproduction. So how does IVF work? So remember from that discussion that we just had, that one egg develops out of a group of eggs, and the rest of those eggs for that month undergo a process called atresia. Well, IVF basically harnesses that whole group of eggs. And so the problem why IVF is not significantly more successful in, let's say, women who are with low ovarian reserve or women who are over a certain age is because that initial group consists of less eggs and lower quality eggs. And so some women require multiple cycles. So everything in IVF kind of depends on that initial group. And a lot of the lifestyle intervention and the supplements that people recommend essentially work to improve the quality and the quantity of that initial group of eggs that ovarian stimulation is going to go after. And so ovarian stimulation takes about 2 weeks, but basically, again, it stimulates that group of eggs to grow. Then the eggs are retrieved through a surgical procedure called a vaginal egg retrieval. Most clinics put the female to sleep and then basically take a very thin and long needle and puncture the ovary and then drain all of those eggs. Those eggs then go into the laboratory. In the laboratory, they're either fertilized by a process called ICSI or intracytoplasmic sperm injection, or conventional IVF, where eggs and the sperm are combined in a dish. And then the next day, we look to see how many of those eggs are fertilized. And so those are called zygotes or fertilized eggs. And we then take those zygotes for about 5 to 7 days and grow them into embryos. And then at this stage, the embryos can either be frozen or transferred. Most clinics, certainly in my clinic, we subscribe to the dogma or the protocols of frozen embryo transfers because it allows the female to kind of take a break, allow all of the stress associated with the stimulation to subside. And then the frozen embryo transfer in most people allows for a slightly higher chance of pregnancy compared to a fresh transfer. The issue of the frozen transfer, it delays the transfer. And so some women who are, for whatever reason, need their transfer earlier may not be the optimal candidates for a frozen transfer. But in most patients, if you're able to do a frozen transfer head-to-head, that typically results in a higher chance of pregnancy. Typically, not always. The embryos are then can be tested genetically through a process called pre-implantation genetic testing. Most clinics mandate that you freeze because that testing has to be sent to a different lab for evaluation. Some clinics have the genetic testing laboratory on site. And so I think maybe 2 or 3 clinics in the world are able to biopsy the embryo, get the results the same day for you to do a fresh transfer. They're pretty rare. So how effective is IVF? I think if you look at mathematical comparisons, IVF is probably the most effective treatment for, again, just mathematical comparison, nothing else, for women who are trying to get pregnant. And so for young women, if you do 1 cycle of IVF, if you take all of the data and apply it to everybody equally, it looks like you have about half of the time that you do IVF, you're going to have a baby. That process or that number decreases for women with age, again, because of the physiologic process of a decrease in the quality and the quantity of the eggs. And so some women, as they get older, require multiple rounds to achieve a pregnancy and a delivery. So when should IVF be a definite? So if the fallopian tubes are obstructed, then IVF is the only way to get pregnant with your own eggs, essentially, or any eggs, because the egg and the sperm cannot meet in the fallopian tube. And so none of the other treatment besides IVF will work. So remember, IVF takes the eggs out, fertilizes them in the dish, and then the embryos are placed back in the uterus. So the tubes are completely bypassed. And essentially, IVF was developed for women with no tubes or blocked tubes. And then as it got better and better, it was applied for every diagnosis. But in a lot of women, it's used empirically, meaning we don't know why you're not getting pregnant. Here's IVF. We're going to make you develop all these embryos and then help you get pregnant. If, for example, you want to do genetic testing, for example, if you are a carrier of a genetic disease or you have kids with a genetic disorder, you want to eliminate it from your family, from your offspring, then IVF can allow you to do that because the embryos can be biopsied and the embryos that carry the specific gene or the disorder can be identified and then not transferred. If, for example, you want to choose if you want to have a boy or girl, then IVF allows you to do that. If you're using egg donor or an adopted embryos, IVF is the only way to get pregnant. For severe male factor, for example, if we have to extract sperm from the testicle because there isn't enough of it or there is an obstruction, or if those parameters that we earlier discussed are so low that the probability of conception naturally or through IUI is essentially almost futile, then IVF is the best treatment. And then for women who've tried to get pregnant with other treatments, whether it's Clomid, letrozole, or gonadotropins, typically between 6 and 9 months, and if you haven't gotten pregnant, IVF, again, mathematically speaking, may be the optimal treatment for you. So what are those options that we can provide for you or you can learn about and do on your own that can potentially avoid IVF? If IVF, whether it's ethically, financially, or medically not acceptable for you as a couple or as a patient. So one of those things we always recommend is that you optimize your chances of pregnancy, whether it's spontaneous or whether it's with any treatment that you're undergoing. And the things that we always recommend is, again, the Mediterranean diet, optimizing your exercise regimen, eliminating any kind of toxins, so tobacco, alcohol. Sugar is a big one because we do know that sugar causes an inflammatory response in the reproductive system. Avoiding as much processed foods and sugar as possible. Again, the Mediterranean diet is probably the best dietary lifestyle intervention for fertility. Taking supplements depends on the diagnosis of what the issue is. There are different supplement cocktails that we recommend, again, based on current data. And then depends on what your evaluation identifies, whether it's hormones to support early pregnancy in the luteal phase, such as progesterone, or medications in the follicular phase, such as Clomid and letrozole, can certainly help you get pregnant. And then there's some women that have anatomic problems like blocked fallopian tubes, or they have endometriosis, that if we treat it surgically, their pregnancy rate does go up. So there are medical, surgical, and social ways that you can potentially avoid IVF if that's not something that you're considering, or that's not an option for you. So with us, compared to IVF, the average successful patient spends considerably less on fertility treatments. And that's to include all of the evaluations, medications, and tests. What do we offer? So we offer one-on-one consultations with physicians that go through all of your history and identify any problems that we can address, whether through medicine or whether through lifestyle interventions. Again, we offer all of blood work and sperm testing that goes directly to your house. And then we integrate technologies like Proov to give you the best possible treatment regimen in order to maximize your success. Again, we personalize all of our treatment through the integration of that technology. So again, you're not just getting a standard treatment protocol, you're getting personalized treatment with close monitoring, again, to improve your chances of success with every month. So how effective are we? So if you look at the diagnoses on your left and then the success on the right, you expect about, it depends on the diagnosis, 30% to 50% of everyone to get pregnant at the end of 3 months, and about 2/3 to 40% of patients, depending on the diagnosis, at the end of the 6 months of treatment. All right, so I think we're coming to an end of our discussion. This is our contact information. And we'll move into Q&A. So what I'm going to do is I'm going to stop screen sharing and I'll pull up your questions, and then we can go into all of your questions. All right, so hopefully everybody can still hear me. I'll go through the Q&A first, and then we do have a list of questions that we can go into. All right, and I'll read the question out loud. Again, the questions are all anonymous. Is there something wrong with my eggs if my luteal phase is short? Well, that's a very controversial question. Remember from the slide that we looked at the follicular and the luteal phase, the progesterone comes from the luteal, the corpus luteum. And so the corpus luteum typically has a fixed lifespan of about 13 to 14 days, and that's genetically programmed. If your luteal phase is shorter, it can be genetic, or it can be something specific to that month, or it could be something that has to do with the mechanism that secretes progesterone within the cell. Typically, progesterone is, it's derived from cholesterol. So, and there's a specific process how progesterone is made, but it's under guidance from hormones that come from the pituitary. So there could be an issue at the pituitary receptor, there could be an issue at the ovarian receptor, there could be an issue in the mechanism that produces progesterone. So the answer is it's probably nothing wrong with your eggs. It probably has to do with the mechanism and the machinery in the corpus luteum that is responsible for your luteal phase. So I think if somebody answers this question, they'll win the Nobel Prize, but it certainly would not be unreasonable if your luteal phase is less than 13 days, it would not be unreasonable to supplement with progesterone. And then Amy, I know you're very involved in this, and then you may have some additional information or additional input. I would love to hear what you have to say to answer this question.
Yeah, I mean, my understanding from the literature and everything is, your egg is, if you think about like a chicken egg, right? You have what becomes the embryo, the actual egg itself, and then you have the support structure, the egg, and the follicle, so to speak. And it's not a problem with the actual egg that turns into the embryo, but more of a follicle problem. And so just because you have a short luteal phase doesn't mean you have bad eggs. It means you might not be able to support a pregnancy because you're not producing enough progesterone. And there comes in the progesterone support after ovulation, which has shown to increase live birth rates 20 to 30%. So it's very, very effective. And if it was a bad egg, that wouldn't happen.
Yeah, that's exactly right. The best test for eggs, for the quality of the eggs that we currently have in our armamentarium, is the AMH test, but also like how your ovaries respond to fertility medicine. So for example, if your ovaries respond very robustly, we do know that your ovarian reserve is pretty good. Yeah, I completely agree with Amy. All right, so let's move on. If I have PCOS but I have a regular 30-day cycle, should I be concerned about whether or not I'm ovulating? All right, so ovulation has multiple components to it. One of them is whether or not the egg is released. Like that information is binary. If you're ovulating, that means you're releasing an egg. Again, typically most women, if they have predictable cycles and they can know when their cycles are going to come, they're ovulating. PCOS in most literature has a diagnostic components consisting of irregular periods, increased androgens, whether it's clinical or whether it's biochemical, and then ovaries consistent with a polycystic appearance. And so some women have regular periods, but they have PCOS because they meet some of that other criteria. So as long as you're releasing an egg, meaning as long as you're ovulating, we can be fairly confident if you have regular period that that's occurring. If you want additional information or additional confirmation that you're ovulating, if you have positive proof tests, that would be confirmation. You can always get a blood test, that would be confirmation. But it's uncommon to have PCOS with regular periods, but you can, and it certainly would fall within the umbrella of the diagnosis. Does that make sense? All right, I hope that answers the question. All right, so let's keep on going. Okay, we have a question about thyroid. With underactive thyroid, what levels of TSH should be targeted before starting IVF? Now, that has to do with what the specific diagnosis for hypothyroidism is. There are multiple reasons why somebody would have hypothyroidism, and to answer your question more specifically, we'd have to know what the diagnosis is. But in general, if the hypothyroid problem is due to an autoimmune issue like Hashimoto's for antithyroid antibodies, we typically want the TSH level to be somewhere between 0.5 or 0.5 and 2.5. Now, sometimes the diagnosis is secondary to something else, and we can be a little bit more liberal. I am a little bit more militant when it comes to treating thyroid problems, so my preference would be for a TSH under 2.5 if you have a diagnosis of hypothyroidism. But if not, then I'm not too concerned about it. All right. The next question is, how do you know that an egg is actually released? Is this through ovulation confirmation, such as a Proov test? Okay, so we are never 100%, no, nothing is 100% certain. The only way we know that an egg is released with 100% certainty is if you do get pregnant. Because again, ovulation typically is binary, egg is released or not. And so what the LH surge does, is on the ovary, it causes two things. The first thing it causes is the egg is arrested in the specific genetic stage. And in order for the egg to be fertilized, it has to be in a different genetic stage. And so the LH surge causes the transition of the egg from what we call meiosis 1 to meiosis 2. And the second thing the egg does is all that machinery that Amy talked about that supports the egg, and then goes on to release progesterone. The LH surge converts it into what we call the corpus luteum, and it allows the cortex of the ovary, or the capsule of the ovary, to be open so the egg can be released. And so the way we confirm ovulation is through progesterone levels, where it's blood or where it's urine or PDG levels. But unless you get pregnant, we have no way of knowing that the release of the egg and the fact that that machinery is now making progesterone are in concert. Sometimes egg is not released and you develop something called a hemorrhagic ovarian cyst. though that's pretty rare. The 99% of the time, those two things are congruent, that your egg is released, and again, your progesterone begins to go up. In the minority of cases, those things are not congruent, but I don't want that to be a worry, because in the vast majority of cases, ovulation correlates with egg release from the ovary. All right, so the next question is, what is your opinion on an ERA test for endometriosis? I think that's a great question. That has to do with, I'm assuming, IVF. So the ERA test looks at the implantation window, but it has to do primarily for IVF, because with IVF, we give you progesterone through shots or pills, or any kind of exogenous progesterone form. And so the biggest piece of information that the ERA gives us is, when should we start progesterone in order to maximize your live birth rate or pregnancy rate with a transfer. It doesn't have as much utility in a natural cycle. The better test for endometriosis is something called Receptiva DX. Receptiva DX looks for inflammatory markers of endometriosis in the uterus, and if they're identified, treatment with endometriosis, either with medicine like Lupron or surgery, allows us to get you a better chance of pregnancy after. So if you're looking for endometriosis specifically, ERA is probably not ideal. The Receptiva test is better, but ERA, if you've had, for example, an embryo transfer that hasn't worked, an ERA would give you more information in order for us to personalize your embryo transfer. So the ERA is more specific to that. Let's look at some of the other Q&A questions. All right, one of the questions is, we recently purchased Proov, but on the same day found that my husband has moderately low motility. Is that something that's fixable, or are we limited to do IUI or IVF? We have a 2-year-old son and had no trouble conceiving him. Okay, so the first thing I want you guys to understand is that sperm production is highly volatile, and it changes all the time. So if you have one abnormal sperm test, it doesn't mean that the sperm test is going to be abnormal or the sperm production is abnormal. You should always repeat it to confirm an abnormal value. And the fact that you were able to conceive before gives you a better prognosis as well. So unless you're in some sort of hurry, there's absolutely no reason to not try on your own. So again, but it depends on how bad the abnormality is, and we'd be certainly more than happy to review it with you. Our next question is, how does knowing my progesterone level for the month help me conceive in that month? Okay, so I want to kind of get away from using a single progesterone level as anything that's potentially helpful. A single progesterone level only lets you know whether or not you've ovulated or not. But what things like Proov allows you to do is measure a progesterone pattern. And so that's much more important than having a solitary progesterone value, because a pattern, or multiple days of information, gives you a better clinical picture of what's going on than a single progesterone value. And what it does tell you, what the pattern tells you, is whether or not you could be somebody that could benefit from progesterone supplementation, or even if you could get benefit from treatment, things like Clomid, letrozole, or anything that would increase the number of eggs that you're ovulating. So next question is, should I be concerned that I have a few months of long cycles? One was 45 days, one was 40, one was 37. I've been using ovulation predictor kit and tracing basal body temperature. My luteal phase has been different each month. Should I be concerned? Well, that depends on your age. So a lot of these things, have to do with different underlying issues. So if somebody's over a certain age or getting to the end of their reproductive lifespan, that could indicate the initiation of that process. Sometimes this is a presenting symptom of polycystic ovarian syndrome. But it has to do, it's very difficult to answer this question anonymously. It's something I'd love to discuss with you and give you, a personalized answer. Next question is, what if my progesterone levels are fine, but not high enough for pregnancy? So again, a single progesterone value can only tell you one of two things, whether or not you've ovulated or not. A pattern is much more helpful to determine whether or not you need intervention or not. And when you measure progesterone in the blood, again, it's very variable because it changes with time. And so I don't want you to worry too much about a single progesterone level because it doesn't really tell you anything else besides whether or not you've ovulated in this cycle. All right. The next question is, how does endometriosis impact fertility? Okay, so again, I could talk about this for hours, but if we summarize it, endometriosis has an anatomic impact, meaning that it can potentially cause a tubal obstruction, but it causes an inflammatory effect as well, where it can interfere with egg release. It can interfere with egg transport through the tube. It can also interfere with implantation. So endometriosis has an impact at all levels, and women with endometriosis have a lower chance of getting pregnant, whether it's spontaneous or whether it's with any kind of intervention. So treatment for endometriosis is usually helpful. So sometimes it's surgery to reduce the amount of endometriosis, in your abdomen or pelvis, or sometimes it's medicine to kind of quiet the endometriosis or to reduce that inflammatory component. What you kind of need and want is going to depend on your personal case. And that would be something, again, that we can certainly discuss with you if you're interested. All right, next question is, I am 32 with low AMH. What is the impact on the chance of getting pregnant? So the honest answer is it's very difficult to say. I've known, hundreds of women with low AMHs in their early 30s and late 20s that have gotten pregnant spontaneously. They come to the office and say, I'm nervous. I want to freeze my eggs. And so we freeze their eggs and then they get pregnant in 3 months after that. But that's all, every one of the cases is individualized. If you're 32 and you've tried to get pregnant for 3 to 4 months or, even up to 6 months, and you haven't gotten pregnant and your AMH is low, then that would be my recommendation for some sort of intervention. The intervention would be something that needs to be personalized to you, but I would not, if you've tried and had difficulty conceiving, then I would not continue to wait. But if that answers your question. All right, let's go on. I am 35 and I've been trying to conceive for 8 months. All the testing have come back undiagnosed, including an HSG. Most months I have an LH peak and use Proov and had a good reading. For the last several months, I was not able to find an LH peak and PDG was not found. On a sonogram, my OBGYN saw a hemorrhagic cyst, and then I fall into the normal 26 to 28 day cycle. I started spotting 2 to 3 days after ovulation. Can this be due to development of the cysts? And I'm not, so yeah, the cyst is completely not related to anything that you're describing. If I were to ultrasound everyone at a specific day in their cycle, would find a cyst. So I don't want you to worry about that. But the reason why you're spotting a little bit either before or after ovulation is that if you go back to that graph where it had the hormones or the menstrual cycle, in all women, progesterone slightly drops in preparation for ovulation, and estrogen drops in preparation for ovulation, And so estrogen supports the lining. So that slight drop causes some women to spot. That's really not an issue, and a lot of women have that. I don't want anybody to worry about that. And so when it's undiagnosed and you've been trying to conceive at the age of 35, I think certainly at this point would be a reason to intervene. And then the intervention needs to be tailored to you after all of the choices have been discussed. But there's no reason to continue to try without an intervention at this point, because with undiagnosed infertility, the probability of conception begins to decrease the longer you wait. All right. How do you improve egg quality? Most of that depends on age. And so but as a general rule, we try to avoid as much of those things that has a negative impact on the machinery that surround the egg. Avoiding smoking, alcohol. Exercise is a natural antioxidant. So starting an exercise program. We typically supplement in women who suspect of having poor egg quality with CoQ10, vitamin D, and DHEA. And that's our vitamin concoction for those women who are concerned about their egg quality, or we document findings that are concerning to us about their egg quality. Are progesterone supplements something that has to be prescribed? Yes, the answer is yes. Most states, progesterone is typically provided through a pharmacy, whether it's compounded or brand with a doctor's prescription, because it's considered a drug and a hormone. So there are no progesterone supplements that you can buy over the counter. They have to be prescribed. All right, I do have additional questions that women have submitted to us before the webinar, and then we can move into that as well if you're interested. All right, so the first question that was submitted before the webinar is, curious about thoughts on IUI with low AMH and success rates. IVF isn't an option for us financially with secondary unexplained infertility. Okay, so in your case, it would not be unexplained because your AMH is 0.3. So having an AMH that low, you can talk about the diagnosis of decreased ovarian reserve. So again, mathematically speaking and speaking directly, in terms of the medical success rates, IVF would be a better choice. Now, completely understand that it's not an option for everyone. So I think stimulated IUIs, where you're given medicine to increase the number of eggs that you would ovulate, and combining that with an IUI is a very reasonable approach for this diagnosis in your case. Remember, age trumps AMH for most part. So if you're 35 with an AMH of 0.32, you have a better prognosis compared to someone who's like 42 with an AMH of 0.32. All right, our next question is, I'd like to know the thoughts on progesterone supplementation during the luteal phase. Many doctors dismiss progesterone supplementation, and in my case, didn't even know that this was a thing. So again, this is very controversial, but I think the controversy is being put to rest with the new technologies that come out, thanks to Amy with Proov. Because again, most doctors, when they were trained, they only looked at progesterone as a way of giving you an answer to a binary question. Have you ovulated or you haven't ovulated? And again, when progesterone was measured, it was only a single measurement. So one point of information in time on a physiologic event that occurs over 2 weeks in a very particular pattern, it's very difficult to give you an answer to that, right? And so having a way to measure your progesterone continually at home, which is much more convenient, gives us a lot more intervention. And so if your patterns are suggestive that you need progesterone supplementation, then it'd be very reasonable to proceed with it. You know, some women have a luteal phase of 14 days. We check their urinary progesterone levels; they're all good. They don't spot before they start their ovulation. All of their levels look good throughout 2 weeks. Then that woman would potentially not need progesterone supplementation. But again, that's a general explanation. Everyone's case is a little bit different, and so I don't want to give you a general answer because every case is individualized different, and that's our philosophy. Is there a way to balance hormones naturally and help egg quality at 44? It depends on how that process is in you. Now, for example, just yesterday I did an egg retrieval in a 44-year-old and got 35 eggs, just because that process of egg atresia was significantly slowed in her. And so in her case, we put her on a specific regimen to improve her egg quality because her egg quality was very, very good. Now, in most women, most women at 44, that's not the case. But if you're interested in doing things naturally, then the supplement regimen I talked about is probably the best thing. But if you ask 10 reproductive endocrinologists, a lot of them even have limits on treatment that are 42, 43. So there really isn't much that's extremely effective at 44, but it doesn't mean that there isn't anything that we can do. All right, next question is, I'd like to know around what an average cycle cost, like low to high end with testing, and I'm sure you get it after the consult. All right, so we typically have a discount for the patients that utilize Proov, and so if you want to talk to our physicians, it's about $50 for patients who are using Proov, and then testing depends on what you need. So if you need sperm and AMH testing, that could run about between $250 and about $400, again, depending on the spectrum of the tests that you need. A lot of women that we see come with a lot of tests already done, but treatment lasts between 3 and 6 months and is typically about $289 a month. And what's included in the treatment cycle or the treatment month is all of your medicines, unlimited access to your medical team, and also all of the monitoring parameters that you'll need. Our next question is, how do your uterine polyps affect fertility? And does a polyp removal help with conception? Well, again, it depends on where the polyp is and how big the polyp is and what your prior history is. If you just regularly find a polyp, and a lot of people don't necessarily advocate removing it for improving conception rates. I typically do, because we do know that the polyps arise from that area of endometrium that's resistant to progesterone. So in the process of implantation, if the embryo implants there, then you'd be at high risk for having a miscarriage. So if you've had a prior abnormal reproductive outcome, for example, if you're trying to conceive and you haven't, and people have identified a polyp, I advocate for removal. If you've had a prior miscarriage or multiple miscarriage and a polyp's found, I also advocate for removal. Because in addition to that area being resistant to progesterone, and that's how the polyp originates, the polyp also causes an inflammatory response that can make overall implantation lower. All right. If you're under 35 but noticed a rapid decline in fertility, can we start treatment before? Yes. So any issues mandate intervention. Again, the dates that we talked about in the beginning of the presentation are all predicated on the fact that everything is normal. If you identify any pathology, then there's no reason to wait the 6 or the 12 months at all. All right, so next question is, does elevated DHA is seen in PCOS? Yes, part of the diagnosis of PCOS is an elevated androgen level. Now it can be DHEA, could be testosterone. But DHEA is a precursor to testosterone. So testosterone is made from DHEA. So most people just measure testosterone because there's no real reason to measure DHEA unless you have severe symptoms of high androgen levels. But again, depends on the level. Most women with PCOS have a slightly elevated DHEA. And then some people put you on a specific steroid to lower the DHEA level. By a mildly elevated DHEA is not going to have a significant impact on your ability to conceive or cause a miscarriage. Okay, so low egg quality, taking CoQ10, 800 milligrams a day, great. I'd also recommend adding DHEA, 50 milligrams per day, vitamin D, around 1,000 units daily, some sort of an antioxidant, your choice, and a fish oil supplement. That's kind of my concoction for women with poor egg quality or that diagnosis of decreased ovarian reserve. Again, in preparation for some sort of treatment. Remember, the goal of the supplement cocktail is to improve that group of eggs then that the medical treatment is going to work on to increase your chance of pregnancy for that month. So, the supplement cocktail isn't going to be necessarily effective in helping you achieve a spontaneous egg. It might, but if mathematically speaking, the intent of a supplement cocktail is to increase the effectiveness of the medical intervention that's going to be built upon the foundation of the supplements. Would you be able to do IVF with an A1C of 7.3? What is the ideal number? So for women who are diabetics, the lower the better. Most centers are going to allow you to undergo fertility treatment with an A1C of under 7 because that's the level where the probability of birth defects secondary to diabetes are going to be equivalent to the general population. So above 7, there's a higher probability of birth defects because of diabetes. So my recommendation would be try to do your best to get that A1C under 7. All right, so the next question is, what exactly should I be testing for after multiple miscarriages? So the vast majority of miscarriages are secondary to the egg and the machinery that surrounds the egg being inefficient. And so when the eggs are made, when they combine with sperm, especially abnormal sperm, then the probability of that conceptus or that baby being genetically abnormal is higher. And so that process gets much more common with age. So the vast majority of the evaluations for miscarriages, we don't really find a reason, and we attribute it to that physiologic underlying problem. But we do have to make sure that there really isn't anything underlying that causes you to have multiple miscarriages or puts you at a higher risk for having multiple miscarriages. So the one thing we do test is the anatomy of the uterus. And typically we can do a 3D ultrasound in the office, or some people even get an MRI of their uterus to make sure that the anatomy is normal. Then we want to make sure that you don't have what we call acquired thrombophilia, or you don't have antibodies to specific proteins on your cells that cause your blood to clot abnormally. We call that antiphospholipid antibody syndrome. That's a common thing that we find in couples who have recurrent miscarriages. The other thing we want to make sure is your thyroid function is normal. You don't have undiagnosed diabetes, which are all potentially contributing to an increased risk of miscarriage. Typically, people will test your ovarian reserve to make sure that the quality and the quantity of the eggs is not responsible for a higher probability of having a miscarriage. And then you want to get a karyotype on you and your spouse to make sure that when you make eggs or when you make sperm, there isn't a higher probability of having genetically abnormal eggs and sperm. And so you can be perfectly normal, but you may have like a deletion in the genetic material on your chromosomes, or a translocation, or some genetic material is exchanged between 2 chromosomes. And when you make eggs, that issue is magnified, and then more eggs are genetically abnormal compared to normal. And so those are the base tests that most people recommend, and that's what I would recommend. Remember, the vast majority of these evaluations are going to be normal, and so people will continue to treat you empirically for that. Most common medicine that people prescribe to treat couples with multiple miscarriages is baby aspirin and progesterone. And then ultimately, if that doesn't work, a lot of couples go to do IVF with genetic testing that identify the genetically normal embryos, and then transfer the genetically normal embryos to decrease the genetic risk for miscarriage, because that is, again, the most common reason. What are the infections that cause miscarriage? So again, this is a controversial topic, and for the last 15 years, we didn't really think of having any kind of infection as a risk for having a miscarriage. Lately, though, we've identified that underlying inflammation in the uterus, or something called chronic endometritis, can potentially be a risk factor for recurrent miscarriages. And so we either test or treat people with antibiotics for an infection. And so typically the course is about 2 to 3 weeks of doxycycline as a treatment for chronic endometritis. Again, this is controversial in our field, and not everyone's gonna even test you for it, but the treatment is typically pretty benign and they're risk-free. And if this is a significant issue that could prevent you from getting pregnant or carrying a pregnancy, then the risk-benefit, in my opinion, is worth it to at least test for it. And typically it's done through an endometrial biopsy, or a biopsy of the inside of your uterus. All right, we're kind of running out of time. So again, we're going to answer all of the questions that we haven't got to in email format, and we'll email the people that have asked them, and we'll also try to record answers to these questions and then send that out as well. So I want to thank everyone for their participation. It was an absolute pleasure speaking with everyone. Amy, do you have anything else to add?
Yeah, no, this has been a phenomenal. I think, yeah, I mean, this is fabulous. Like, I was not expecting you to answer all of these questions in such great detail. There's obviously a need for these women to get in and talk to a doctor. I would say, the people that, the Proovers that have talked to Dr. Gary all love him. I've heard nothing but great things. Like, we do have special codes for you guys, so it's very cost effective to at least have an initial conversation, get a second opinion. If you have a doctor that's not really listening to what you're saying, that's kind of the theme that I came across was, my doctor can't advise me or is not giving me the right treatment or whatever. Get a second opinion. It's definitely worth it. Highly recommend, Fertility Cloud. I think is phenomenal, especially in the environment of COVID and being able to do things virtually. I'm living proof that we don't all need IVF, and so if anybody can, work with a virtual fertility center and get the help they need without needing IVF, that's my ultimate goal. So yeah, please, reach out if you still have questions. I thank you guys for all the time. I mean, this was 90 minutes. I'm just shocked that you guys answered all these questions. It's just phenomenal. So thank you very much. I appreciate it.
Yeah, absolutely. So I think, we're very happy to do like a standard presentation, but there's so many questions. I think maybe next time we'll plan on doing just a question and answer session, and we can incorporate all of the, the underlying fertility, physiology, pathophysiology, treatment strategies into doing a question and answer session. And so, we can maybe plan another 60, 90 minutes, and we can address, any of those questions as well. And we'll be more than happy to do that as well. Again, all the questions are anonymous, and everything that we didn't get to today will be, we'll take the time to answer, whether it's an email format or video format, and then we'll answer. So if you didn't get your questions answered, please contact the webinar registration link, or you can contact us directly, and then we'll ensure that we answer your questions for you.
Yeah, or if you're on the Proov user group, or on the back of your Proov pack, contact with that email. We'll put you in touch with them as well. So we'll get those questions answered. Absolutely.